her 20 years down the road. Cancers, just from an anatomical point of view. And that was really the main rationale behind changing the way we look at things at stage. Because ultimately, when you look online as a patient, sorry. When you look online as a patient and say, oh my God, it was just diagnosed as stage 2, like, what are my odds of having a recurrence and being alive from this, like, in the next 5 years? What you're going to see online right now really doesn't reflect that, because depending on what that patient has as far as ER, PR, HER2 status, grade, and whatnot, that may color what that patient's survival risk of recurrence and whatnot would be. So the big difference is now we are incorporating, in addition to the anatomical status, which includes, as I said, tumor, metastasis, and nodal status, we're including ER, PR, HER2, tumor grade, and in certain circumstances, genomic signatures such as recurrence score. And right now we're using recurrence score, but over time I foresee that more signatures are going to be incorporated in this, as some of them are prospectively validated. Okay. So the main point of creating this was really to get a better definition of what the clinical prognostic stage is, and clinical prognostic stage is what we decide the patient has before surgery. So the patient already had a core biopsy, you know they have a tumor, but all you know is that they have imaging. You really may or may not know what the lymph node status is. If they don't have palpable lymph nodes or something that shows up on a mammogram or ultrasound, you may just say clinically no, 0, right? But then you also have the pathological prognostic stage, which is what you do after the surgery. So this new system is actually incredibly good for patients that are going to have surgery up front. It doesn't work quite as well when you have patients that have upfront neoadjuvant treatment, because obviously you're relying on the clinical prognostic stage, but the pathological stage is really not going to come until much, much later. So this works better for like patients that go through the classic route of you had a diagnosis, you had a surgery, and then you're going to have a recurrence. But the idea was to incorporate biologic factors. So the histologic grade, what was chosen was the Nottingham classification, so the Nottingham combined histologic grade, ERPR, HER2 status. And even that is like a work in progress, because HER2 guidelines have changed just in my lifetime, like I don't know, 3 or 4 times. So like keeping that straight now is hard. And as I said, genetic signatures like recurrence score. And it combines that with the anatomical stage. So what's the point of combining that? Like, I mean, do we still care about anatomical stage? Of course we do, because in this case, size kind of like does matter in some circumstances. But I think most importantly, we have to be aware that, you know, even though we like to think as the United States as the center of the world, we are not really just the center of the world. There's a whole world out there that does not have access to the same things we have. So if you are having a patient being diagnosed with breast cancer in Asia or in Africa or even in some places in Europe, they may not have access to recurrence score. They may not have access to HER2-targeted treatment. So what this means to them is very different than what it means to us, where we do have all these things. So it is still important to incorporate an anatomical stage, and obviously there's still a lot to be said about the prognostic value of lymph nodes and tumor size and whatnot. So the key points of doing this was to really facilitate these stratifications, like in a much more refined way, to really, when you look online and see, well, if I have a stage 2A cancer, what is my odds of having recurrence and dying from this? In a much more refined way, where you really have an accurate account of like, what does it mean to have not just stage 2 breast cancer, but stage 2 breast cancer that is either ERPR positive or negative, HER2 positive or negative, high grade, intermediate or low grade, and so forth. And unfortunately, though, in order to do that, it is quite complicated. Now, as you can imagine, when we're dealing with not just 3 factors that you're looking at, but now 6, you have really 152 possible combinations of T, N, M, grade, ERPR, HER2 positivity, plus a recurrence score. So it does make it challenging. So this is not easy, and it's unrealistic that anybody would know how to stage a patient by heart having to do this. So you are going to have to rely on incorporating this in your electronic medical records or some sort of online tool to help you, like, plug in the information and it spills out what the patient stage is, because there's no way you're going to keep straight 152 possible combinations for your patients. So to refresh what do we perceive is important in order to come up with like what a patient's ultimate prognosis would be, I'm going to go back and I know I'm going to insult some people where I'm going to go very basic and start from scratch of like why, how do we treat people, but I think it's important to go back to the basics and remind ourselves like how do we make this decision process of staging somebody and most importantly determine what they're going to be treated with. So when I see a patient in clinic, the two things that go through my mind is who am I treating and what am I treating? Because that's obviously going to color what my decision process is going to be. So who am I treating has to do with how old this patient is. So if you have somebody who's 92 years old, you're not going to treat them the same way if they're 32 years old, obviously. Because ultimately what you care about is curing somebody of breast cancer. If that breast cancer is not going to kill that person, then it's not a priority. So if that person has comorbidities that are going to kill them before the breast cancer can, same thing. You're not going to go crazy to treat them if they're going to die of liver problems. So performance status, comorbidities, and age actually do matter quite a lot in your decision process when you're seeing a patient in clinic. So you can't detach the tumor from the patient. Now, when you say that like average 50-something-year-old healthy woman, obviously breast cancer is a big priority because chances are that person's not going to have any other problems to shorten her lifespan. So therefore we focus on what are we treating. And that has to do with this prognostic and sometimes predictive factors that we look at, which go beyond anatomical status. So let's start by looking at the first one, histology. So histology does matter because now we know that not everything that's breast cancer behaves the same. So granted, 80% of what we see are what we call ductal carcinomas or no special type carcinomas. And indeed, they behave in that exact fashion where they start in the breast, but nevertheless, obviously they can metastasize either via the hematogenous route or lymphatic route. But there are other cancers that really do behave a little different. So even when you got a patient with lobular cancer, which is the second most common histologic type, nowadays we know that those cancers are not very responsive to chemotherapy. So you have to take that into account because if you have somebody that presents even with a stage 3 lobular cancer, you know that chemotherapy is not going to do that great of a job. So that patient's prognosis may not be as good because you're not going to have as many quote-unquote weapons to treat that patient with. So histology does matter, and acknowledging that there are some special histologies, some of them that behave very well, like mucinous or tubular, that you barely need to do septum lymph node biopsies and you take it out. I almost think of them as non-cancer. But nevertheless, there are some special histologies that are not that good at all, like metaplastic cancer. So taking all that into account makes a difference. So histology is still something we have to look at. Then we look at size. But we can't really separate size and grade if you think about it, because not everything that's of a certain size behaves the same, and the grade changes that. So when you look here, let's take this group here for a second. So small tumors means from 0 to 1 centimeter. Look at the 10-year overall survival difference between a tumor that is between 0 and 1 centimeter and has a low grade, so grade 1, 93% overall survival in 10 years. But look what happens when the grade is grade 3. It goes down to 88% survival in 10 years. So grade 3 does change quite dramatically the behavior of this cancer, regardless of the size. So you can't really ignore grade, and that's why it's important to incorporate it when you're staging patients, because the size becomes a little meaningless when the grade is high. Look at this patient, for instance. If you have a patient that has stage 2 anatomically, based on tumor size between 2 and 5 centimeters with grade 1, where the overall survival is 88%, that's actually not different than somebody who has a stage 1, but yet grade 3. So shouldn't this women be the same stage? They should. But nowadays, if we just go back to what we were doing, they wouldn't be on the same stage, would they? This one would be a stage 1, this one would be a stage 2. With the new classification, that would not be the case. This one here and this one here would be the same stage because they have the same 10-year overall survival. So you really can't separate size from grade. And then obviously lymph nodes still matter, and this graph here shows very clearly that the more lymph nodes you collect, the worse survival you have. Now, the lymph nodes, as everybody knows, they really do have more of a prognostic value rather than an anatomical value, so you really don't have to go crazy and take all of them out and whatnot. So the reason to go after lymph nodes is to determine, are you going to need radiation or not? What is the prognosis? Do I need to add more chemo? Like I suspicion it will be worse. So the lymph nodes are a very important prognostic factor, but not as important as far as local control. So just to refresh what TNM kind of like is in this day and age. So T, again, T1, 2, 3, and 4 really has to do with size, where less than 2 centimeters is what we call T1, between 2 and 5 is T2, more than 5 centimeters T3, and if you have chest wall or skin involvement, it is a T4. Lymph nodes have like changed over the years, but to make a long story short, if you have kind of like confined lymph node burden, it's 1, and 0 is obviously no lymph node metastasis, and 2 is when you have lymph node metastases that are either fixed, X-ray, or intramammary, and then 3 now is if you have intraclavicular or supraclavicular lymphadenopathy. Before, like this used to be considered M1, now it's not considered M1 anymore because it is within the same location of what the tumor is happening. And obviously M0 is no different test, and M1 is the same test. So moving on to the prognostic and predictive factors, which really is what changed the staging nowadays. So ERPR also has evolved over time. Obviously we consider anything that's more than 1 centimeter ERPR positive, but does it clinically matter? It does, because the amount of staining and the percentage of cells that stain positive by immunohistochemistry for estrogen and progesterone does color how well these people are going to respond to endocrine therapy. So there's something called all-red score, which takes into consideration precisely the immunohistochemical level of staining, so if it's weak, moderate, or intense, and the percentage of cells that stain like that. And the combination of that spills out a score that goes from 1 to 8. And anything that has an all-red score below 3, say all-red score 1 or 2, really will not probably derive a significant benefit from endocrine therapy, because what that tells you is that about 90% of this tumor won't care for hormone blockers. Only about 10% does. I'm not suggesting that these people won't have to take the endocrine therapy, but realistically they're not going to benefit as much. So I think even though we consider anything above 1% ERPR positive, I think if I saw a patient that only has 3% positivity on ERPR, I don't know if I would bother giving her endocrine therapy because these drugs are not water. They have a lot of side effects and they affect people's quality of life. So nevertheless, ERPR positivity is not only prognostic, but also predictive of benefit of endocrine therapy, so it's clearly something very important that we have to account for. HER2, same thing. So having HER2 positive cancers usually portends a bad prognosis in the absence of treatment. However, with current HER2-targeted treatments like trastuzumab, enoblituzumab, and others, we do really see an impressive decrease in the risk of recurrence and an improvement in overall survival. So I would argue that patients now that have stage 1 ERPR positive, HER2 positive disease are incredibly curable because they really have so many options as far as targeted treatment that their risk of recurrence is truly very low. And lastly, now we have all of these molecular signatures, and God knows that I can't keep them straight in my head and what all of them do and how different they are from each other. But the point is that, not that I'm being partial, but I am going to be a little partial to say that there's only one of the signatures that is actually predicted, and that's the recurrence score one, the one we call Oncotype DX. And the reason for that is because this is the only one that when you look at, let's forget the prospective data, which I'm going to talk about in the next slide, but if you look at just the retrospective data that was done in thousands of patients, so the validation and testing of this really is the only signature that can tell you that you benefit from endocrine therapy, but you also benefit or not benefit from chemo. The other signatures just tell you if you're going to do well or not, but they don't tell you what happens if you treat that patient with chemo, or if you treat that patient with antibiotic. You can infer, and they all have the same prognostic ability. But the only one that has had proven predictive ability of benefit of treatment is the recurrence score. So typically that is the one that I choose because it tells you what to do. So the recurrence score signature is based on 21 genes that, depending on their over or under expression, as you can see here, will literally spill out a score that goes from 0 to 100, and depending on how high or low that score is, that will translate onto a risk of recurrence. And that is provided the patient will take endocrine therapy. So that's very important to remember because the prognostic ability of the test is regardless of that, right? If you have the oncotype signature and it's a low score, it will tell you that the patient will have a well-behaved cancer. But the predictive ability of the score only happens if the patient commits to take endocrine therapy for at least 5 years. So that's an important thing to remember when it comes to your patients.
Ingrid,
Yes.
can you comment on the ER a little bit more? Because I know for patients that have the 5% positivity, they technically are positive. And so when you put their staging in, it's always a struggle for me because they're going to get counted as ER positive and
Right.
staging, but they're really not that positive.
So that becomes a judgment call because at least based on the state, and I don't know if everybody heard Amelia's question, so I'm going to repeat that. So she asked me to comment a little bit more about ER/PR positivity and what you do with the patients that end up having low ER/PR positivity, where when you plug in within the staging, they get plugged in as positive, but clinically they may have not so relevant ER/PR expression to make it positive. So the staging does not account for that, obviously, and it probably should, because as I said, somebody that has ER/PR positivity of 5% will have a very different biologic behavior in tumor than somebody that has 95% ER/PR positivity. So to me, it becomes a judgment call of how you use the tool. So if you clinically perceive that 5% ER/PR positivity is not enough to call that patient ER/PR positive, then you should plug in the model as negative because you realistically will not see a substantial benefit from the addition of endocrine therapy in reducing that patient's risk. So nowadays, even though the definition is ER/PR more than 1%, even when you look at clinical trials inclusion criteria, some investigators have been a little bit more flexible in calling quote-unquote triple negative cancers that have up to 5% ER/PR positivity because clinically it is not that meaningful. Those patients do not really derive benefit from the endocrine therapy. So what I would, and again, if you repeat that I said that, I'll deny it until I die. but honestly, what I would recommend is that if you have somebody that you really don't believe is going to benefit from endocrine therapy, when you plug it in the model, just plug it in as ER/PR negative, because otherwise you're going to have a false sense of what that stage should be and what that prognosis should be over the next 10 years. Does that make sense?
Are there any discussions about adding ER?
Oh yeah, there
You
are
already have
some.
6 different things, so that's
Correct. So again, I think the big disclaimer of the new staging process is it is a working process. So this is being deployed as is, and it's very imperfect. It's going to make a lot of people mad and confused, and it's going to get more confusing as we go. So it may take years before it gets to a point where it's refined enough, where there's really not much room for it. Well, but what about this? What about that? So there is discussion about incorporating the level of staining and the level of percentage of cells. That's not going to happen that quickly. So I suspect we're going to have version 8, 9, 10, 11, just like iPhones. Every year we're probably going to get a new version of that rolled out. And it's going to get more confusing as we go, but right. Correct. And they may not call it all right, but as long as you get the percentage of cells and the staining level, you can infer what the all red is. So, but not the staining. Yeah, that is a problem. That is a problem because it does make a difference. So somebody that has, let's say, 10% ER/PR positivity in terms of percentage of cells with strong staining means a totally different thing than weak staining with the same percentage of cells. So that's already a different alpha score. So I think it is important to maybe talk to the because there's no reason why they couldn't put that in the report. So, but anyway, so all right. So obviously, with the recurrence score signature, we talked a lot about the retrospective data and what that meant, and that's really what we were going on when the staging was rolled out. But since then, obviously, we had presentations and updates on this very large prospective study called TAILOR-X. So TAILOR-X was a prospective study evaluating the role of this recurrence score signature in determining who would benefit or not from the addition of chemotherapy in the setting of having a tumor that's up to 5 centimeters in size, node negative, ERPR positive. So based on the knowledge we had previously from retrospective data, we knew that this signature could stratify patients in having what we call low score or low risk for recurrence and benefit from endocrine therapy only, versus the high score with high risk of recurrence, where they know that they had to take both endocrine therapy and chemotherapy. But it was a big question mark of what to do with the patients in the intermediate group, where you knew they obviously benefited from endocrine therapy, but it was unclear if chemotherapy was really going to add a lot to what endocrine therapy was already doing. Now, before the prospective study reported, when you looked at the profile of the recurrence score, you see that what was defined as low score was a score between 0 and 18. Intermediate was 18 to 31, and anything above 31 was high. But yet, when the prospective study was done, the cutoffs were very different. They were essentially 0 to 11, 11 to 25, and 25 and above. So why did they come up with that? So I'll come back to this slide in a second, but just show you here, how did they come up with that? Oops. No, let me just So essentially, the reason that the cutoff for 11 and 25 were chosen has very much to do with the confidence interval between the curve, that is the main curve that determines risk here. So this is small, but I'm going to try to guide you through. So if you look at 18, which falls about here, and draw a line up to this point here, which is where the main curve is, a score of 18 corresponds to a 10% risk of recurrence, provided you take your endocrine therapy. Whereas a score of 31, which falls about here, corresponds to about a 20% risk of recurrence. So if you look at the confidence intervals lines, if you take the more conservative route and look at the upper level of the confidence interval on the curve, and you use the same cutoff, 10% recurrence and 20% recurrence, what you get here is 11 and 25. So they wanted to be as conservative as possible in not under-treating patients. So they wanted to be really, really sure that nobody was going to miss out on chemotherapy if they needed it. So that's why they used 25 as the upper cutoff for what they call high risk, because there's no way that anybody below that or above that was not going to have chemotherapy if they needed. So there was no margin of error in there. And that's why those scores were chosen instead of the quote-unquote conventional ones that were used before. So the design of the study was actually pretty simple. So if you had a recurrence score under 11, so low risk, you got endocrine therapy only, that was arm A. If you had a recurrence score more than 25, that was arm D, you got both endocrine therapy plus chemotherapy. And if you had a patient that fell with a recurrence score of 11 to 25, which is what then they consider the intermediate group, they were then randomized to receive either endocrine therapy alone or endocrine therapy plus chemotherapy. As you can see, the majority of patients ended up falling within this group, and this is not a coincidence, because the other reason for choosing this cutoff is literally because, based on retrospective data and ongoing data that Genomic Health had, the brunt of patients, like almost 70% of patients, really would have scores that would fall between this. So knowing what to do with this patient population was really a big priority. So you fast forward to the end of the trial results, where 10,000 patients were accrued, but as I said, almost 7,000 were randomized. The first part of the study that reported was the part that had patients with a score under 11, so the low-risk patient, and fast-forwarding at least 5 years, how did these patients do? And as you can see by the curve here, great. So these people clearly had benefit from endocrine therapy, and they really don't need anything else. So their survival rate at 5 years is literally almost 100%. And that actually persists when you look longer and you see that in subsequent slides. So at this point, the follow-up wasn't that big, but nevertheless, it's still a substantial amount of patients followed prospectively with endocrine therapy alone, where you can rest assured that if you have a cancer that is node negative, ERPR positive, up to 5 centimeters with a recurrence score less than 11, they will do great. Usually, yeah.
Apropos of extending endocrine therapy beyond 5 years, did you look at those results and say, that's not the crowd that we should have another 5 years of therapy?
Correct. So let me repeat your question out loud, just for the sake of the people online. So the people that have a recurrence score, so node negative, up to 5 centimeters, recurrence score less than 11, great overall survival at 5 and 10 years. Do they need extended adjuvant therapy beyond 5 years? No. This is exactly the crowd that probably would not benefit from that, because they will do well, and some of these women will do well even without endocrine therapy, because their cancers are just very well behaved from a biological point of view. So this is the crowd that would not benefit from 10 years endocrine therapy and will probably just stick with 5 years. Even with premenopausal patients, this is also the crowd that I would not consider a strategy like the soft or text trial, where you'd add ovarian suppression to your endocrine therapy. So very well. But obviously the group of interest was the intermediate group. And the intermediate group here, as presented recently at ASCO and published in the New England this year, was the results for more follow-up on that arm A, which still continued to the grade. But now the group of interest arm B and C, which were the ones that were randomized to chemo and endocrine therapy, also allowed us to be pleasantly surprised that these groups did not behave any differently. Now, this is not a superiority study, this is a non-inferiority study, but nevertheless, it was powered to really detect a lack of difference between the groups. So what you can see here is for arm A, at 9-year follow-up now, the chance of distant recurrence is 3%. For arms B and C, regardless of the addition of chemotherapy, there's about 5% distant recurrence risk. So clearly suggesting that for patients in this group, chemotherapy is not helpful. And then for arm D, which is the folks with high group, there's a 13% distant recurrence. So obviously underscoring the biology and the importance of this, considering that most of these patients actually have the same stage, right, anatomically, because we're taking people that are all lymph node negative, all of them ERPR positive, all of them with tumors up to 5 centimeters, and the brunt of them had tumors about 1 to 3 centimeters in size. So anatomically they all have the same stage, but clearly they have very different outcomes based on biology relying on ERPR status. So there is a little granularity to this, because the data that I showed is the overall data. But there was a subset analysis done stratifying patients based on age. And they really just did a simple cutoff looking at more than 50 years of age, less than 50 years of age, using that kind of as a surrogate marker for pre- and post-menopausal status. And what was seen is that for patients who were younger than 50 years of age, even though most of them obviously did well, especially with the lack of chemo in arms B and C, there was some that, depending on how high their score was, that they didn't do so well. So when you look at what the recurrence score was, if it was truly low, meaning between 0 and 15, even for young women, they did behave well, where they still had a 3% distant recurrence, just like the postmenopausal women did. And they really did not have any evidence for chemo benefit. But when the score was between 16 and 25, that was a little bit different, because especially on the higher end here, the addition of chemo did do something. Now, if the addition of chemo did something because it causes patients to become amenorrheic and really supplement their need for estrogen suppression, remains to be seen if there's anything special about chemo, or the chemo was just a convict to suppress ovaries. But the point is that for patients that are under 50 years of age, lymph node negative, ERPR positive, with a score between 16 and 25, a discussion about chemotherapy still needs to occur. I'm not suggesting that all of those women need chemotherapy, but the discussion needs to happen because they do derive some benefit from the additional benefit. So the point I'm going to make, though, with all the slides in preparation to talk about the staging is that really accounting for these other factors that go beyond anatomical staging really do matter because the outcome varies so tremendously based on that. So it really cannot stay as just anatomical staging because that does not reflect what happens to people down the road. So how is the sausage made? How did they come up with the staging? How did they figure it out, like what was going to be stage 1, stage 2, stage 3, and so forth? So there were several bodies of data that came from MD Anderson and other groups, at least looking at what factors should be incorporated. So there were several previous validation and testing cohorts that ultimately led to the choice of ER, PR, HER2, and grade as the prognostic factors to be incorporated within the new staging system. And then they took advantage of this national cancer database that really contained thousands of patients, more than 200,000 of patients that were treated between 2010 and 2011. And why those years and why the database? Because you don't want to take people that did not get treated with, let's say, HER2-targeted treatment. Because if you do that before with a database that goes before 2005, you're not going to have an accurate depiction of how the HER2-positive patients do. So they had long-term follow-up on this database, and they used this database as a training and validation cohort to incorporate all the prognostic factors that were there, and lo and behold, they did come up with the survival calculations for all these groups, and that's how they came up with what was going to be stage 1A, stage 1B, 2A, 2B, and all forth. So these were the two big data sets that kind of led to that. And this was published now this year in JAMA, looking at how the anatomical stage and prognostic stage behave. And you can see the curves are not actually quite identical. There's a little variation here when you use prognostic stage versus anatomical stage. But there's also some overlap. So either way, the combination of both is what ended up making sense to create the staging. So the clinical prognostic stage, as I said, is something that we use for all patients. So that's when the patients were diagnosed. You have the data from imaging, mammogram, ultrasound, MRI, and whatnot. You have the data from the biopsy. So you already can infer quite a lot on what the patient's clinical prognostic stages will be. So that provides some guidance of what the initial treatment is. So let's say if you have a patient who's stage 3A or 3B, obviously you may consider neoadjuvant treatment before surgery. If you have somebody who presents with a stage 1A or whatnot, surgery will probably be the first step. But nevertheless, this provides some sort of base for comparison for all patients regardless of the sequence of events. So the clinical prognostic stage is something used for all patients at diagnosis, regardless of what the next treatment choice will be. So based on the clinical information that you obtain from the history, physical examination, imaging, or whatnot, you're going to come up with that stage. And I'm going to just show you an example of what that would look like. So, for instance, if you take, how is that different from what we've been doing here before, right? So if you take somebody who has, from a TNM point of view, either a T1 or T2, N0, or N1 microscopic, you can have HER2 status if it's positive or negative, ER status if it's positive or negative, PR status positive or negative. The clinical prognostic stage group varies quite a lot based on that. So, for instance, if you have somebody who has HER2 negative cancer but positive ER, positive PR, the clinical prognostic stage group, and the greatest one is 1B. But if they have HER2 positive cancer, ER positive, PR positive, they also will have stage 1B, despite the fact that they have ER positivity, which technically pertains to worse prognosis. But because of the treatment benefit, these patients don't behave any worse than the patients that have negative ER status. So in that sense, this is consistent. But if you have negative HER2, negative ER, negative PR, they already are 2A, even though they have a tumor size and lymph node status that is comparable to women that have changes in ER, PR, and HER2. So even though this is confusing, whatnot, it kind of makes sense because in your head you already determined what this patient's risk is going to be, and you already made decisions on that, regardless of what the stage is. So now we have the stage to go along with that and reflect what we were thinking and what the treatment recommendations would be. The prognostic stage are actually only valid for people that are going to undergo surgical resection at their initial treatment for cancer. So this is not applicable for patients that undergo neoadjuvant chemotherapy or endocrine therapy. So it uses both pathological T, pathological N, clinical metastasis or not, the grade, ERPR, and the whole stuff. And in here, once you have the surgical specimen, you also can add recurrence score signatures if appropriate, if the patient has ERPR positive cancer. So when you have both the clinical stage and the prognostic stage, obviously the pathological prognostic stage will supersede the clinical one. But either way, both information should be available within the chart if all possible. And again, here things would look a little bit different as well, where you have a little bit more granularity, because at some point you're going to, like beyond this, you're going to add the recurrence score when appropriate. But again, the granularity here varies quite a lot of what we were doing before. So the gray area is how we would have staged this patient before, but now things can change a little bit based on HER2 and ER. So I'm not going to go through that again because you pretty much get the point of how to do this. So there's some other considerations though that again have not been fully ironed out, but at least there's a beginning where what to do with patients that have microscopic disease. So the N1 tumors. So those are cancers that have lymph node involvement, but the involvement is less than 2 millimeters by H&E. So we know that these patients clearly don't behave as badly as the ones that have truly positive lymph nodes, but back in our minds we know they don't behave quite as well as the ones that have like really truly negative lymph node involvement. They are not very common, like it's only 2% of all diagnoses. So for the staging, if you have cancers that are between T2 and T4 primary tumors, and you have N1 this is actually going to be the same as T2, T4 primary tumors with N1, so we're going to call this stage 2B. So this is one important consideration to remember. For T1 tumors, that is not the case. For T1 N1 they will be stage 1B, so they'll be the same as somebody that has no negative cancer. So there's a big distinction and something you have to remember. The N1 will have a different connotation based on the size of the tumor within the MIG classification, so that's one consideration. The other thing that happened within the staging, thank God, is that they took out LCS as actually being cancer. This is now considered a benign thing, a benign entity. So it's really more of a marker of risk of cancer rather than a cancer per se. So this is no longer considered a malignancy. So this was now removed from TNM staging. Obviously not DCIS. DCIS is still considered cancer and is still the TIS.
A question about the 2Bs there.
Mm-hmm.
Do the T2 to T4 N-limits behave the same way as the N1s?
Yes.
When they're classified
Yes.
as 2Bs? The
Correct.
databases and
Yes. Exactly. So that's what I'm saying. So the connotation of what the MIG means varies with tumor size. So if you have a bigger tumor size, having microscopic involvement of lymph node is worse than having negative lymph nodes. So they should be treated and considered the same as N1s.
Did you ever consider putting LGI in the system? Because it's almost worse sometimes, and there's nowhere in the stage you can.
Correct. So there may be room to include that, but I think because that ends up being uncommon, and what I suspect happened is that they may have looked at LVI, and it may not have made too much of a difference based on whatever else we're looking at. But it's something that probably will also be clarified sometime down the road. But nevertheless, right now, at least we have some granularity of what to do with this N1 mix. So how does the genomic profile factor in so far? So the only time that the genomic profile factors in so far is if the genomic recurrence score is less than 11. So it's not yet accounting for what the score is if it's above 11. So the reason for that is because the above 11 score prospective data didn't exist when it rolled out. So this probably will be further refined as we now have the prospective data. But if the TNM staging is T1 and 0 and 0 or up to T2 and 0 and 0 with any grade, HER2 negative, ERPR positive, and a genomic recurrence score less than 11, the pathological prognostic stage group will always be 1A. So this is a very specific category in there that really downgrades the staging quite a lot just because of the incredible long-term outcome that these patients have when they have either T1 or T2 and 0, ERPR positive, HER2 negative, any grade cancer. So one thing to note though is that what the staging is not suggesting is that you have to do a recurrence score in every patient. So you don't need to do this. If you have it, you incorporate it in the staging, but it doesn't mean that you have to do it in everybody. That's one thing. So let's see if there was anything else I was going to say. Yeah, so this again, it may change further as now the prospective data for the intermediate group gets incorporated into this. So when we have version 9 or version 10 of this, we may have more granularity based on genomic profile signature. So what are some of the limitations of that beyond just like the cumbersomeness of like figuring this out in your head? Obviously, it's very useful for patients undergoing surgical management first, but most of the patients that have triple negative cancer and HER2 positive cancers that by anatomical stage have at least stage 2 end up being treated in the neoadjuvant setting. So the clinical prognostic staging will work for them, but the pathological prognostic staging will not. The other thing is that that cohort, that 200,000 women cohort that was used to create the new system, they didn't have quite enough follow-up data. I mean, if you think about it, those were women treated between the years 2010 and 2011. So we may be missing out on what happens to these patients with ER-positive tumors that are now recurring 20 years down the road and whatnot, for which the prolonged endocrine therapy may be of value. So it's not accounting for that. So that obviously has to be accounted for moving forward. As I said before, it is cumbersome. I mean, you really do need some sort of online tool or something incorporated in your electronic medical record system to be able to do this, because nobody can retain 152 variations of the stage in their head. And as I mentioned before, the global applicability is limited because a lot of places in the world don't even test for HER2 because they don't have HER2 targeted treatment so at the point, and they don't have access to genomic signatures either. So the bottom line is that as cute and important and whatnot that this is, it's really not generally applicable for the whole world yet. So in conclusion, I think, again, it is important to incorporate the prognostic factors, so it definitely makes sense. I think it's a move in the right direction. It's just like switching, like in our institution, we just switched OMRs from whatever we have to Epic. It was painful, but there's some advantages to it. So, yeah, it was painful, but we got used to it now. We've had it for a year and we grew on it. So, same thing here. It's painful. It's a change. People don't like change, but it was a necessary change. So I think it does make a lot of sense. It will really allow us to have a much better, like, everybody talks the same language, and when I say stage 2A, you know exactly what I mean, rather than, well, stage 2A, but what is the ERPR positive status? What is the HER2 negative status? So you kind of like have a much better global sense of what you're dealing with. So it facilitates communication between providers. And I think it really helps formulating a treatment plan where, the treatment plan you formulate for somebody with a stage 2B cancer is very different than somebody with a stage 1A. So obviously it really takes into account the true prognosis and what you really need to do for these patients. So it still determines the extent of disease, but it helps formulate a treatment plan. It really facilitates communications between providers. And most importantly, it has a much more standardized collection of essential data. So when you look back at the databases and whatnot, it's really much more streamlined and again, much more applicable than what it has been. And I think that's about it. I know I didn't have a lot of slides, but that leaves time for questions. So, thank you.
People that under 50 crowd, because that wasn't really, I don't know when they decided to do that subset analysis. But I guess
So that's a very individual discussion with the patient, and we end up taking into consideration a lot of the things that new staging brings in. So give a couple of examples. So let's say you have somebody that presents with a recurrence score of 20, and they're under 50, and they have a tumor that's about 2.5 centimeters, and they have grade 3. I probably would give that patient chemotherapy. Same scenario, grade 1, I probably wouldn't. And then I'll talk about ovarian suppression and whatnot. I think the biggest challenge we have is not knowing why the chemotherapy is important in that group. As I said before, we all suspect that it may have something to do with the fact that chemotherapy ends up promoting amenorrhea and transforms a lot of these women into postmenopausal women, working as if they have ovarian suppression. And that may be where the benefit comes from. But we can't rule out a benefit that comes from chemo itself. I mean, there may be a clone of cells within that tumor that really was not dependent on endocrine therapy, but benefited from the chemo just for the sake of chemo. So that is not something that we can go back and look and analyze, and there, I don't know if there's ever going to be a trial now that's going to just look at premenopausal women, randomize them to ovarian suppression, the whole 9 yards from an endocrine therapy point of view versus chemo plus tamoxifen. So because the field has changed ever since the design of the trial happened and how the follow-up happened and the information that was collected, there are questions that will remain unanswered. So I think the discussion has to happen at a very individual level with a lot of other things will have to be taken into consideration. Even the patient's age. I mean, somebody that is 32, it's very different than somebody who's 47, even though they're both under 50. So again, all those things end up coloring how you're going to lead the discussion and ultimately what is the final recommendation you're going to give. So I think there's a lot of granularity in that group. So my recommendation is individualized discussion, but the word chemotherapy needs to be part of that discussion. If all of those women are going to need chemo, it's probably not true. And some of them, I think there's room to discuss, well, we won't do chemo, but we will do LHRH agonist plus an aromatase inhibitor instead of tamoxifen. And we're going to do this for 10 years, like not the whole combination, but we're going to do endocrine therapy for 10 years rather than just stop at 5 years. So all of this now is we are extrapolating the data a little bit. And even though we don't have data, we have to use the data the best way we can and use our clinical judgment, because at some point we have to let doctors be doctors and really interpret the data as they see fit. So.
But it also may depend, what you said earlier, on how true and consensus they are.
Exactly.
And I tend to ignore RT-PCR as a real determinant of it, but I wonder if we should look at it. I mean, the patient is quote ER positive, but they're just barely near RT-PCR.
Correct.
Is that a read that we should take on?
I think it is, because it does tell you what the protein level is and how much receptors you have in here. And if you don't have the receptor, you, like, depending on the drug you use, you actually may not have as much benefit as you think you're going to have. So I don't think we can ignore that. I mean, because ultimately that's exactly what the recurrence score signature relies on. It's how much expression of ERPR you actually have. So it is an accurate depiction of how sensitive. That's exactly right. So it is somewhat indicative of how much benefit they would get from endocrine therapy and how much more swayed you are to give them chemo. So to me, the closer their score is to 25 or above, the more likely I am to be a little bit more nervous about not giving them chemo, especially if they have a bigger tumor, higher grade, and whatnot.
Can you comment at all about the borderline T4 scale alpha and how y'all do that at Vanderbilt?
So T4 is T4, and it's always a higher risk, but I'm assuming you're referring to that, like, little touch.
Yeah.
That little touch on the skin, the little touch on the chest wall. You know, I think obviously, from a surgical point of view, that's obviously something that has to be addressed, and you want clear margins, and obviously these people are going to get radiation and whatnot. Again, I think you have to look at the composite, because sometimes patients will have T4 lesions, but just because their cancer was unfortunate enough to really be so damn posterior that it ended up causing a little chest wall invasion, which is very different than a cancer that clearly started in the middle of the breast and grew all the way back. So that's a much different beast of a T4 than the first situation is. So I think you just have to incorporate that into everything else. So I almost think as T4 as variable and try to think if these were not touching the skin or the chest wall, how would I stage this? And then I can like crank the risk up based on the T4, depending on how everything else looks. So a T4 with a big tumor and positive lymph nodes is obviously a much bigger issue than a T4 that has no involved lymph nodes and is a tumor that's only 1 centimeter in size.
So any dermal cancer involvement, you're gonna call it T4?
You will call it T4. Yes, but again, I think exactly. There's granularity there.
Or, I mean, she's gonna get radiation.
Right, that's what I'm saying. So I think there are T4s that their only significance really becomes local regional control. They may really not have that much implication as far as what you're going to do from a systemic treatment point of view. Because they really may just be T4s because of location and not necessarily because they're biologically bad behaving tumors. It's not like, they're not there's inflammatory and then there's like T4 that just happens to be there because it's where the cancer started. So I think you have to take that into account. So we really do try to individualize that. I mean, as I said, everybody will get negative margins, radiation, the whole nine yards from a local regional control point of view. But I think that there's room for tweaking the systemic treatment because not all T4s are alike. So,
Thank you.
yeah.
Let's thank Dr. Meyer for coming.
Thank you. It's not the talk that's paid for, it's using the staging that's paid for.
Yeah.
You can even read that on your phone.
Thank you.